This conference will now be recorded.
If he had S1, Q3, T3. Beautiful. I'm not too shut something down.
I'm like, I got big tickets. Yeah, yeah.
But I was. Yeah.
All right. So everybody in Austin's done with their tests. So we're about to get started on something. Get started on cardiac emergencies. Before we get started, I just want to address. Cool. I just want to address something real quick. So who, and it's cool because you're not alone. Who all got the question wrong about the baby putting oxygen on the baby? Right? If you haven't looked at it and you put that the parent needed to hold the baby, I can tell you right now you got the question wrong. So I've done a lot of research on National Registry. I'm sure Mike has done his fair share of research. Becca's done research on National Registry. There is a pool of questions in which National Registry automatically assumes that the general population and the majority of people taking this test are going to miss. So when I state, I expect y'all to miss this question, don't take it as a shot towards anybody in the room. It's all about the wording in the question, right? It's all about how you look at the question and how you read the answers. The reason why that answer was wrong, if you put that the parent was holding the child, is because you stated, or in that, the answer stated that you put the mask on the baby's face, right? The second you put that mask on that baby's face, that baby is going to lose his ever-loving mind, right? The reason why the other answer was the most appropriate answer is because all it stated, very simply, was that you were going to try to keep the baby. It did not state in which manner, whether that means handing the baby to parent, whether that means you hold the baby, whether that means laying the baby on the stretcher. It did not state. And it said that you would administer high concentrations of oxygen. I expected a majority of people to miss that because I knew the second they saw the thing about the parent, that was going to be kind of their go-to, right? The reason why I put those questions in there, I can inundate you with those questions. And you can ask her. We sit here, I went through 155 questions to make that test, and there's a lot of questions very, very similar to that. The reason why I don't inundate you in the mindset of what like keeping it simple means and answer, because that's how National Registry gets you. National Registry gets you by putting two answers up there that look like they're probably going to be right, but then there's one little discerning factor in there that makes one more appropriate than the other, right? The discerning factor was the fact that you put that mask on that baby's face, and that's why that answer was wrong. Get in that mindset when you're taking these tests, because there's going to be two answers on the majority of these tests that are the most appropriate, but there's going to be one that's just a little more right than the other one. I understand it's frustrating. Trust me, I have taken 3 National Registry tests, and they piss me off every time, but that's how they're set up. They're set up to ask you which orange is the most orange, right? Which blue sky is the bluest sky. And if you don't believe me, Google National Registry and you can find 8,772 memes and TikToks about how terrible National Registry is. It is set up for failure. That's the reason why EMT basics have a first-time pass rate of 60% and a third-time pass rate of 72. It's because people look at these questions and they're like, oh, this is the right one. But it's not the most right. They have gone through years and years and years and years of question making and data research and all this crap to try to make your life as difficult as possible when it comes to taking that test. I promise you, the only thing, I am not trying to set you up for failure. I am trying to prepare you for what you're going to be looking at
I
in 3
appreciate
months
it.
whenever you go take this
I
test.
could not do that. I needed a Mikey in there.
Yep. Yep. And that's what gets people, right? The thing that gets people the most is the simple questions that they overthink. Same thing with that one, right? The only reason why the other answer was right is because it did not directly state how you were going to keep this baby calm, and it did not directly state how you were going to administer oxygen, right? How would you administer oxygen and try to keep a baby calm? Right? Blow by oxygen and give the baby to the parent, right? You don't want to put a mask on the baby's face, because when you put the mask on the baby's face, he's going to freak out, right? That's the only reason why that answer was correct, is because it did not tell you how you were going to keep the baby calm, and it did not tell you how you were going to administer oxygen. All it said was that you were going to keep the baby calm and that you were going to administer oxygen. And it's that simple, right? So I'm not trying to set you up for failure when I put those questions in. I expect the majority of people to miss those questions, and I try to be as polite as I possibly can when I say that, but that's the same thing the National Registry does. And you can ask her, because National Registry put out many studies that they have made a test bank of test answer or test questions that they expect greater than 90% of people that take that question that they're going to get wrong.
They're rude.
And it's just the way it is. I wish there was an easy way to make it make sense, because it don't make sense to me. But I've taken 3 of those National Registry tests, and every one of them suck. They suck. They're difficult, and they make you want to bang your head against the wall.
I got it, but I had to read them. You assist somebody with their inhaler, and she's still coughing and not sounding good. You give her another dose, don't you?
So she goes from respiratory distress to respiratory failure.
Yeah,
because she
it's
now
confusing,
has
right?
altered mental
What is the
status.
barking cough?
It's
So
true.
seal cough is
It
crude.
just says you gave her inhaler.
Yeah,
it
but
didn't
like
help,
that
and now
that
she's altered.
epiglottitis, whenever you get that
So she's
inflammation
now
and
respiratory
you get that
failure.
like
So
barking
now
like
she
cough
gets
because you have that
assisted ventilation.
constrictions of the epiglottis, that's when you start getting the drooling and all that stuff.
Because even the book says
It's
that it's more common. It's more common. But nasal flaring and grunting are also kids.
yep. Don't choose croup. What did Becca say? The number one keyword for
It's true, but you can
epiglottitis
also
was
see nasal flaring
drooling,
more in children than
right?
adults, and you can also see grunting and respiration.
What's the number one keyword for croup?
Yeah.
Seal light cough. That's what, remember, she said that last week when she was going through this. Those are the 2 key words for those 2 very, very distinctive processes. And that's the process you have to try to hone in on, is some of these very simple things, right? You just got to, and it's
What
hard,
do you mean?
right? I wish I could make it easy for y'all, but if I make it easy for you here, you won't
No,
pass
it's just
National
our
Registry.
verdict. Yeah.
And so I got to, so no, I think the basic test is,
They changed it.
oh,
They changed it this year. So it used to be however long, just it's an adaptive test. So like you would take the questions. I believe
now it's 120 questions?
it's 120. It's a set amount of questions. I don't think
No.
so.
The questions are adaptive, but when we took our national registries, the basic test and the paramedic test was adaptive in the sense of you may get cut off at 70 questions or you may get cut off at 150.
Yeah. Yeah. You either pass
So
or
they're
fail the
changing
crap,
it
whether you quit
next
at
month.
70. Yeah.
If you take national registry past April 1st of this year, you will be a mandated 120 questions. You will have so many hours to take the test, because they took the skills portion of national registry out and they have added it into the test. And so now they have those like didactic questions where they give you the scenario and you can have like multiple answers and stuff like that. People said they're doing the medic test thing. Are they giving y'all the scenarios on the medic test where you can pick multiple answers? So, yeah. And so that's a lot of what National Registry has turned into. And I can reach out to a couple of people that I know have taken that. And what I'll try to do is look for people that take it like after April 1st before y'all take it, just to try to get a little bit more information on it. I'm sure there's going to be a couple of people that kind of put out their own little like studies or whatever after April 1st, whenever they really start rolling out this new testing system. But it's a lot of scenario-based questions, a lot of multiple choice where you like pick multiple answers and stuff like that. The adaptive thing. So now they're doing adaptive testing where if you start missing a bunch on one style of question or one category of questions like operations or cardiac or respiratory, they're going to start hammering you on those questions. And that's the way it's always been. They did it to me. I can tell you right now, when me and Becca walked in to take our paramedic test, we're driving down the road and we're like freaking dreading life. We're driving down the road and she's like, God dang it, I really hope they don't give me operations questions. Like, I don't want operations questions. I freaking hate them. I don't want to freaking answer 872 questions about what size oxygen tank does what. And I was like, frick yeah, I don't feel like dealing with all these weird disease process questions and like these freaking going through diagnostic of these weird things. I got hammered with those questions, right? She got hammered with operations questions because they will pick up what you're like slightly weak on and they will hammer you with it. And that's why a lot of people, if you ask them about it, they're like, I've had 872,000 OB questions because a lot of people aren't super strong about OB stuff, right? So they just get hammered with OB questions. So that's where it's become adaptive now is they find your weakness and they just hammer you with it. On the flip side, National Registry has put out statistics that they know in the first 10 questions whether you're going to pass that test or not. Make that make sense. You're about to take a 120 question quiz, but they know within the first 10 questions whether you're going to pass or not.
How's that? That doesn't make any sense. Because what if you just like answered great and just fucking shit?
I don't know. They have put out studies that have said that within the first 10 questions, their system, their AI computer generated bullcrap knows whether you're going to pass that test or not. So me and Becca walked in there, and don't feel bad, right? Because me and Becca walked in, we sat down at a computer. If you don't know Pearson VUE, when you get there, and I think Mikey talked about this, right? You got to pull everything out of your pockets. You got to empty your hat. You got to put everything in a lockbox. You walk in there, you get a piece of paper. They give you a pen. They say anything you write on that piece of paper at the end of this test, you have to turn in and hand it to them, right? It is a very strict system. You got cameras that watch you. It's a very strict system. When me and Becca walked in to take our test, we were still on the adaptive system because we both had to do the skills test. So we were still on the adaptive testing where, you know, you get 70 to 150 questions. You just never know. If you got cut off at 70, either you passed it with flying colors or you sucked, right? There's just no in between. We sat down at back to back. We started taking our test. Somehow she finished 20 minutes before me and we got cut off at the same amount of questions. I can't read very well, but, you know, I digress. So
it says an hour and 20 minutes. I'm trying to find like exactly how it's set up for y'all because they just changed it like last year.
yeah,
So it used to be like it was adaptive and it either cut you off at 70 to 120. So as soon as they were sure that you had like above a 95% passing rate, they'd cut you off. So
I take the test on that I trusted you.
is that what it is?
yeah,
Whenever you
this
do
one
like the
says
national registry scenario.
there are 135 questions that each candidate must answer in 2 hours and 15 minutes.
So if we don't get cut off at 7,
So that's not the way it is anymore. You have a standard amount of questions now. So
But
yeah,
that says AEMT exam, so it might be. Oh, hold on.
So,
I'll figure it out. For
we're
you.
all trying to figure this national registry thing out, but I do know the way the questions are set up. And that's why I'm trying to like throw some of those questions at you just to kind of get your brain kind of thinking a little bit deeper, because that's the way these questions are set up. Again, I don't mean to set you up for failure, but when you walk up to me and say, yeah, I missed that question, and I look at you and go, yeah, I expect most of everybody to miss that question, it's because of the wording in that question. You have to be very decisive about how you read these answers and how you answer those questions. So it's nothing against, because like I said, I mean, we're passing, we have a 90% average for this class. So I don't think anybody in this class is dumb by any means, right? The class in general is doing fantastic. I think everybody is trying really hard to do what they're doing, right? When I put certain questions in there, I expect people to fail it. Well, not fail the test, but miss that question. It's just my expectations just because of how it's worded. Because I have to look at it and think about it on a national registry level and think like if this was a national registry question, how would they answer it? And that's the reason why some of those questions I expect the majority of people to miss. And I can see them. I can actually pull y'all's test, break it down by question, and see who missed what questions. And every single time the questions, I'm like, yep, the majority of people are going to miss this question. I put it in there. I can go back and look later on, and that's what ends up happening. And it's nothing against what y'all are doing. It's just that's the way the National Registry sets stuff up, and so I want y'all to get ready for it now. It's a pain in the butt, y'all. I really, I really wish it wasn't. Honestly, I took a CDL school. I went to CDL school. Her dad's a pilot, and I can tell you right now, driving a freaking 70,000-pound semi truck down the road. I took a big test to do all that, driving tests, all that stuff. Her dad's been a pilot for like 20 years. He flies around all over the place. Those tests are like cakework compared to National Registry. So there's doctors that go in and take National Registry tests because we used to do EMT classes for doctors at Grady. We didn't, but they did. And they just fell the piss out of it because they would think about it too much, and they would think about it at a doctor level instead of a EMT level or whatever.
So from what I'm finding, it's still adaptive at 70 to 120 questions.
Yeah,
you get 2 hours. So if you make it to like question 100 and it cuts you off, don't freak out. If you make it to 120 and it cuts you off, don't freak out.
You're going to.
You're gonna freak out, but
listen, man, I can tell you right now, I killed my phone like 4 times every single day, sitting there refreshing National Registry, because you don't get like you sit there on a little National Registry website and you see this thing. It's like prepared to test, prepared to test, prepared to test. And you sit there and refresh your phone 20 times every hour, and you're like, all right, I'll get this thing eventually.
And then finally one pops up and it's like examination scored, and you're like, I don't want to look at it. It's terrifying, but it's good. It'll be good. Yeah. So, any other questions on this test? So, okay. So there was another question where you gave the bronchodilator, someone got altered mental status. Now what do you do? Any questions on that question? Okay, so the
key component.
Yeah, key component of that one
is
because she's now
status.
altered. What does that take her from respiratory distress to what? Respiratory failure. So she inefficient breathing to sustain life. So now you were bagging her. Okay. Yeah, cardiac emergencies. I love this chapter. I'm not going to go into as much detail as I could. I'm going to try and keep it simple for y'all. So our objectives: review cardiac A&P. That should be review. Kind of like the respiratory was, where we reviewed the lungs. We're going to review the cardiac. We're going to identify different types of cardiac emergencies, how they present, how you treat them, and then treatment modalities. We're going to overview the treatment modalities. So what are 2 big medications that we give for cardiac problems? Aspirin and nitro. Good. So we're just going to go over that. So this should be review, right? So right atrium gets blood from where? Okay. From the body. Yeah, from the vena cava, superior and inferior. Comes in from the body, goes in the right ventricle. Where does this go? Lungs. And then it comes back, right? And then where does it go from the left ventricle? Back out to the rest of the body. So from the body, lungs, comes back in, out to the rest of the body. Okay. Yeah. Away, artery, so it starts with an A, is away from the heart, vein towards the heart. Yep. And then our little valves here, right? So do you remember the TP, my ass? Tricuspid, pulmonary, mitral, and aortic. So review the components of the blood. Most of it is plasma. More than 50% is plasma, right? And then you got your buffy coat, so leukocytes and platelets. What's a leukocyte? White blood cell. Yep. Someone told me that they had a friend named Luke that was white, so that's how they remember. I like it. And then your erythrocytes, right? So our job the job of the heart is to pump blood. That's its job. So We have a mechanical part of our heart that actually pumps blood, and then we have an electrical part of our heart that's the electricity is telling which part of the heart to pump, right? So electrical charge creates a mechanical response, which is pretty cool. And it requires a constant supply of oxygen and nutrients. So if you're looking at the heart, here's a little picture, but here's a little diagram. So you open this up, you have your little SA node, AV node, that's all your electrical part, but then you have the mechanical part. Our mechanical part gets blood because our heart needs a blood supply too, right? So we have all these little arteries that go around our heart. Okay, so there's a bunch of them. They're in the back, they're in the front, they're up underneath. You can't really see very well. I'm not going to take that thing off. So those are coronary arteries, right? So whenever one of those coronary arteries get blocked, what do we call that? Heart attack. Yeah. You'll hear it referred to as a STEMI or an OMI or an NSTEMI, but that's what that means is something is cutting off the circulation to the heart. Okay? Does that make sense? That was like one of the more difficult things for me to wrap my head around when I was going through EMT basic. Like, oh yeah, I guess the heart does need its own supply of blood. So here's some of the major arteries. So you have your left anterior descending, right? It wraps around. You have your circumflex, which goes all the way around. And then this is the right side. So depending on what part of the heart is affected, you're going to see different signs and symptoms. We can tell whenever we look at a 12 lead what part of the heart is affected. So a big thing is if it's like this RCA over here on your inferior side of the heart, you're going to have a lot of heart rhythm problems. So that's where you get like your bradycardia and your weird heart blocks because your pacemaker is right here. What is this sign? Levine's sign, right? Because Adam Levine, right? Adam Levine. All right, so ACS, acute coronary syndrome. This is also called cardiac compromise. So if you're seeing that, they're interchangeable. Anytime the blood supply to the heart cells is blocked, that's ACS. We have signs and symptoms that we'll see somebody and be like, yeah, they're probably having a cardiac event, but really, can we rule this out in real life? No, we can't, right? So we have to have a high index of suspicion whenever our patients are presenting with certain signs and symptoms. Like chest pain, that's a big one. But like I was telling, I can't remember who I was talking to on Saturday, but our books are written because they're very kind of, what's the word? They're altered to like males, right? So we have certain signs and symptoms that we can see, and they love to teach, oh, chest pain, left arm pain. That's more prominent in males. So there's a lot of other signs and symptoms that we're going to see, especially with women, with diabetics, that they all have different signs and symptoms. So keeping a high index of suspicion on all your patients for cardiac stuff is really important. So when our heart muscle cells go without oxygen, that leads to cell death, right? Because cells need oxygen to work. What's another word for cell death? Does anybody know? There's ischemia, which is like low oxygen, right? But whenever those cells actually start to die, there's a word for it. Infarction. Yeah. So ischemia without low oxygen, and then infarct is the actual death. So this is a visual of there's something blocking one of those arteries on the outside of the heart, and then you can kind of see this discoloration that's supposed to show you like that's where that's starting to die, right? So signs and symptoms, chest discomfort, that's a big one. So anytime you hear chest pain, anytime you see chest pain, treat it like chest pain. Chest pain is chest pain is chest pain, right? So we have a bunch of different things that can cause chest pain. You can get like anterior wall chest pain. Has anybody in here had like a bad cough for like a week, and at the end of the week you're like, my chest hurts because I've been freaking coughing? You last week. Yeah. Yeah. So having them describe their pain is a big one, right? So like we said, we don't want to be like, is your pain sharp? And they're going to say yes. And then you're like, is your pain dull? And they're going to say yes. So kind of have them explain to you what their pain feels like. You might get some really random answers, but it kind of gives you a general idea. They can kind of fit into these categories of whether it's dull, whether it's sharp, whether it's aching, right? We also ask about radiation. So jaw, neck, arm, does it radiate around to the back? Does it shoot down their left leg? Is it just this thumb? You might get those kinds of answers as well. Women and diabetic patients commonly present with abnormal signs. That's where you'll get like the weird abdominal pains, or I've had where it's just their left shoulder hurts and they're having like the widowmaker, right? So just keep a high index of suspicion. You're going to hear that out of me a lot today because we've had a lot of patients that were like, oh, this isn't anything. And then we do a 12 lead and we're like, oh crap, there is something. So just keep that in mind.
My first clinically diagnosed in-field heart attack, STEMI, the only presentation and the only thing he was complaining about was gas in his chest. He had no pain. He said nothing was hurting. He said he felt a little short of breath while he was walking around, but he just had a ton of pressure in his chest. He felt like he had a bunch of gas.
Yeah.
Yep.
So you can have like indigestion, heartburn. We get called for that a lot, right? Because someone don't know if they have indigestion. So that's kind of where the history taking comes in. But you still want to do your full scope of running these tests on these patients. So if they're like, yeah, I just ate like 20 hot wings and now I have chest pain, you could be like, all right, that could be indigestion, but I'm not going to rule out that it's not a cardiac issue just because of that. So some other signs and symptoms you might see: nausea, vomiting. The skin signs is a big one. So cool, pale, clammy. If you walk in and someone is gray, there's probably something going on. Syncope. What is syncope? Fainting. Yeah. So lightheaded. You can have near syncope, and then you can have syncope. Near syncope is like, oh, I felt like I was about ready to pass out. You should still treat it as if it was syncope. You still want to do the blood sugar test. You still want to do the 12 lead. Sudden onset of sweating, abnormal pulse. So if I feel someone's pulse and it's like boom, 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 what kind of pulse is that? It's irregular, right? So these are things as you walk in and say, hey, my name's Becca, what's going on today? And I'm feeling that pulse. Those are all things you should take mental notes of, like, yeah, it feels regular. It feels fast. It feels slow. You don't have to sit there and count it right off the bat, but you can tell, like, hey, this feels funky, like there's something going on, and make sure you bring it up to somebody if you do feel that. Abnormal blood pressure. They can have really high blood pressure, or they can have really low blood pressure. So that's kind of one that you might see both ends of that if it's a cardiac issue. And then this impending doom. I've had a lot of patients that are like, yep, I'm going to die. And I'm like, and then they die. So impending doom is a real thing. I had one lady screaming at my face, y'all are going to let me die. I feel like I'm going to die. And about 2 minutes later, I was pumping on her chest. So it's a very real thing. If people feel like this, don't freak out with them, but just, keep that in mind that it's a thing. Generalized weakness is another weird sign or symptom that you might see. Grandma is 90 years old. She's like, yeah, I've just been feeling really weak. I had a friend that ran a call. Someone woke up, felt extra tired. So he ran a 12 lead and they were having a heart attack. So weird symptoms. Yeah. So like vertigo, if I remember correctly, vertigo and dizziness, like the thing that differs between the two, if I remember correctly, I think vertigo is you feel like you're spinning and dizziness feels like the room is spinning. I think I'll confirm that. Is that what it was?
Yeah.
Yeah, there's dizziness and vertigo is a weird one. So you have your primary assessment, right? We've all been through this. I know we have because we did it on Saturday. You're going to check your ABCs, right? If they're unconscious, we're going to start with what part of our ABCs? Circulation. If they're unconscious, you want to check for a pulse, right? Explore the chief complaint. So we're going to ask those questions. The OPQRST, the sample, we're going to get clarifying questions. When did this start? Have you been not feeling well for a couple weeks and then all of a sudden have you had a cough for 2 weeks? We're going to explore those chief complaints. Baseline vital signs, that's a big one. I noticed on Saturday, I know in your skill sheet, it doesn't say till later to like put a pulse ox on somebody. If I'm checking their breathing quality, I'm just going to toss a pulse ox on right there. That's a really good way to get a baseline set, especially because in that airway section of your med sheets, it says put on the oxygen. So it tells you whether you're fixing them or not. Like, where did they start? Where are they at now? Because if I walk in and throw a non-rebreather on somebody and 5 minutes later I put a pulse ox on and it says 100%, I'm like, oh yeah, they're fine. I don't know where it was before that non-rebreather. Some things, pale skin, another word for it is pallor. I don't know if that's how you say it. That's how I've always said it. Pallor. But that's what they're talking about. If you ever see that in a test question, it's that pale skin. Swollen ankles and feet, what does that tell you? Yeah, they have edema. What's a big cause of edema? It has to do with your heart. Heart failure. Yeah, so what side of the heart in specific? Right side. Why is it the right side of the heart? It's the side that's getting blood from the body. So whenever you have heart failure, whatever comes before that part of the heart is what's going to start backing up fluids. So your right side is failing, it's not going to be able to efficiently get that blood from the body, and you're going to start to pool. With the left side, it hits the lungs before it goes in the left side. So if you have left-sided heart failure, you're going to get that fluid back up into the lungs. Just build up a pressure. Yep. So any kind of increased pressure in the chest is going to cause that JVD. Acute pulmonary edema, which is what? Fluid in the lungs. What lung sound is associated with pulmonary edema? Crackles. What's another word for crackles? Rails. Good job. And then medical alert jewelry. Not a super common thing, but make sure you are looking for it. Some people have tattoos. Some people wear jewelry. Yeah. So we're going to talk about a 12 lead placement. I know some people that have walked or have rode around here have seen us do a 12 lead placement.
What happens to them stickers?
They're right here. I made new stickers. So this is not
This is
how,
Bob.
That's Bob or Matt, whatever. So one good thing, you want to start with the limb leads, right? So your right arm, right leg, left leg. So they call them limb leads. In the pre-hospital setting, I prefer to go on the torso for a few reasons. Whenever somebody starts moving their arms around a lot or we're hitting a lot of bumps on the road, we'll get something on the EKG called artifact, and it makes it really hard to see it. So kind of avoid that artifact, we're going to put it on the chest. We're going to avoid any bony areas. So like try to avoid putting it on somebody's collarbone because you're going to, and try to, if you can like feel a pulse in that area for whatever reason, don't put it directly over the pulse. All of that can affect how the 12 lead looks. So our right arm, left arm, that's all like easy, right? Because they say RA, LA. But if they don't have those on them, one thing you can do to kind of remember, so white on right, white's on the right, right? Smoke over fire, and then clouds over grass. That's how I remember. So sometimes they don't have the RA, LA, LL, whatever. So whenever we put these on, these are our electrodes today. You want to do it in front of the camera so they can see? Did you hit record on this?
Yeah.
Okay, cool. All right, so RA, we're going to put it. You didn't, did you?
Yeah, I think I did. No.
Yeah, there's like, oh, whatever. Nobody's going to be able to refer back to this.
Just hit the escape button.
That's what I did, and it didn't do anything. Alt tab?
It's all right. I'm sure CJ did it.
Okay, cool. All right, so right arm, right? We're going to put it not over the bony area. We're going to do right leg.
Right arm.
So this would be what color? White. White on right. Clouds over grass, right? What color is this one? Green. We're going to put it on the belly. Try to avoid those hip bones. Some people put them right directly over the hip bones, and it causes problems. Okay, LA is what? Left arm. What color is that? Black. Smoke over fire, right? So LL would be your left leg. So what color is LL? Red. Good job. Okay, so then we start getting into our 12 lead placement. So you can have just a 4 lead without the 12 lead. He's getting very acquainted with Matt here. Mm-hmm. So for V1, it's going to be the 4th rib down, right? So you can be the person that sits there and counts each rib. That's fine too. But one easy way for me to do this is just go like this with my hand, start at their collarbone. V4 is going to be right where your pinky is. Same idea, you don't want to put it directly over a bone if it's kind of sticking out, and you don't want to put it directly onto the sternum, right?
No, sometimes you just get a little bit of booby artifact.
Yeah.
It's fine.
Yeah, they're like little amplitudes will change and stuff.
Yeah,
But so
alright.
4 fingers down, right side of the sternum, that's where V1 is going to go. Okay, V2, same exact spot, but on the other side of the sternum. Okay, at this point, when I was first learning, I skipped V3 at first and I went straight to V4. So V4 is going to be mid-clavicular, right? So mid-clavicular is what?
Nipple line.
Nipple line. I don't know what that means. Okay. All right, so nipple line, it's going to go mid-clavicular. It's going to go 1, 2, 3, 4, 5 ribs down. So usually if you can just feel like right where that little crest is, like where their booby starts, it's going to go right here. So V4 nipple line.
We're trying to show Austin too.
Yeah. Okay, if you do have a lady or a man that is blessed, back of the hand, lift up, right? Assess, don't caress, right? So back of the hand, lift up, V4. Sometimes those boobies get a little bit bigger and it needs more than just one hand. So you got your partner over there, you know, it's happened.
Get a crane out, get a jack out.
Yeah, you're over here like.
We had a
Uh-huh.
we had a little girl that we used to work with. Her name was Megan's family. She's about this tall girl.
Yeah.
She was a little girl, and she was up under a lady with both hands, and her hand trying to hold some stuff up.
Yeah.
So I could do a 12 week on her.
Yeah.
So, well, sometimes the integrity thing kind of, get a
It
work around
happens. It happens. All right. So then from here, after V4, I skip V5 just to make it easier on myself, and I go V6. So V6 is going to go mid-axillary. What line is that? Middle armpit, right? So right over here. Sometimes I tell them just do a chicken wing, and they'll bring their arm up so I can put it here. So V6 is going to go here, and then it's going to go there. And then from there, you just fill in the blank spaces. So V3 is going to go in between those two, and then V5 is going to go in between those two. Easy peasy, right? So one big thing, make sure your electrodes aren't touching. Whenever you're putting them on, make sure they're not touching because that can give us false readings. There is a way that if you switch these, you can tell, looking at a 12 lead, you can tell whether the right arm and right leg is switched or whatever. Yes. So as an EMT basic, you can place and obtain a 12 lead. You just cannot interpret it. So even if you are a BLS unit and you have the capabilities to do a 12 lead and you're suspicious, please do the 12 lead. Some places allow you to transmit those 12 leads, so you can just hit a button on the monitor and it sends it right over to the hospital. If you don't have those capabilities, just keep it with you and then show it to whoever your protocol tells you to show it to. Sometimes it was like you send a picture, a text message to a supervisor. Yeah. So yes, you can obtain an EKG, cannot be interpreted. Some EMTs can interpret them, but not officially. So if you're like, I know how to read this thing, don't put it in your chart that you interpreted it, please. And then sometimes you look at it and you're like, I know what normal looks like, and that's not normal. So I'm going to talk to an adult. And I still do that to this day. All right.
I do too. I just call her.
I love
I
EKGs.
know the other night when I was looking at it, I'm like, yep.
Yeah,
Them
those are some
squiggles
squiggly
look
lines.
squiggly.
Yeah.
It looks
So,
normal, so those must be.
yeah. One big thing that I do want to point out on this slide is the earlier the EKG is obtained, the better. So with our chest pain patients or suspected ACS patients, we want to obtain it within 10 minutes of initial patient contact. So that is important because EKGs change. All it is a snapshot of their heart in that moment. So that EKG has potential to change over time. So it's not wrong of you to be like, hey, I have the 12 lead on. I'm going to take contiguous 12 leads like every 10 minutes until I get to the hospital. That's not a bad idea. Somebody might look at you funky. I wouldn't look at you funky. Yeah, you might as well. You already have the stickers there. You don't want to mess with all the wires again, so just leave them on until you get to the hospital. This is what the electrodes look like right here. They can look different than that. As you guys have seen, ours look a little bit different than that. They're kind of a pain in the butt because if you tear the wrong spot, then you tear the wrong part off, and it's a whole thing.
It happens.
Yeah, don't put the electrodes on t-shirts. There has been instances where you go to put the electrode on and it like folds up onto the t-shirt, and then it's like your monitor's yelling at you. So if your monitor's ever yelling at you and you're not seeing a rhythm pop up, just check your placement, make sure they're all down. Really hairy chest people, you're going to have a hard time getting that placement and for them to stick. So do with that what you will. You might have to razor blade their little hairs off, but whatever. Yeah.
Oh, we do. We carry razors on the ambulance.
Yeah, we do.
We also have pediatric defib pads. They make good waxing tools.
Yeah, you rip them off. So on the flip side of these electrodes, there's usually a little circle of like jelly. It's like a jelly consistency stuff. So that needs secure contact with the skin. So that jelly part needs to be on their skin. If they do have moisture, whether it's diaphoresis, whether it's they just got done swimming, what have you, just wipe it off and try and get them to stick the best you can. There will be instances where your patients, they just don't stick on them because they're like actively being diaphoretic and you're wiping and wiping and wiping. It's like wiping the end of a marker. It just keeps coming off. So anytime somebody has a chest complaint call or possible cardiovascular accident, incident, whatever, consider oxygen administration. So the big thing that they're teaching now is you want to keep that oxygen saturation between 95 and 99%. Does anybody remember why we don't want to keep it at 100%? Yeah, so too much, you can have more than 100% oxygen. Exactly, because it only reads up to 100, so they can have more than that. Too much oxygen in like an affected area of the heart or like the brain, if we're dealing with stroke patients, it's like a free radical, so it can actually start to damage tissue. So say that they're satting at 95%, but they have really bad chest pain, they're cool pill diaphoretic. Would I put them on oxygen? Probably not. I'd put them on a nasal cannula and I just wouldn't turn it on until I needed it. So lower than 95% you want to treat. If they are, say, respiratory failure or respiratory arrest or completely apneic, right? You can still ventilate them. Don't ventilate them because they said they had chest pain before they went unconscious or unresponsive or stopped breathing. You still want to bag these patients if they stop. Usually your position of comfort for a patient with ACS is sitting up because it's kind of like has to do with like getting that weight off their chest kind of thing. So keep them in a position of comfort. Unless they want to stand up in the back, don't be like, you can't sit like that, right? All right, aspirin. Why do we give aspirin in possible ACS calls?
What does it do? I like it. Technically, it is a blood slipperier.
That's the medical term for that, by the way.
So technically, it makes your blood slippery because it doesn't allow the continuous buildup of platelets.
Yeah, it's a platelet inhibitor. So what it does is it doesn't so much thin the blood, it just makes those little blood cells slippery. So if there's a buildup, you're allowing more blood to get past that blockage, right? So it's a COX-2 thrombane inhibitor. But anyway, all you need to know is it's an antiplatelet aggregator, right?
Nerd.
So what's your indications for aspirin? Chest pain, suspected ACS, right? What is ACS again? Acute coronary syndrome. Good. All right. What's your contraindications?
Don't look at the board.
Oh, yeah. What's your contraindications? GI bleeds, I heard. Allergy to aspirin. GI bleed again. Yeah. A double check. Polyps, nasal polyps. What did you say back? Yeah, any kind of like vomiting. If they're actively vomiting, you want to be careful. The GI bleeds is a big one because it's an NSAID, right? So non-steroidal. Blah, blah, blah. Yeah. So you have something called an aspirin triad. So not so much all of it is a complete contraindication because asthma is on that aspirin triad. And if someone has asthma and they're having chest pain, you can still give them aspirin. You just need to be considerate that aspirin, somebody can have an aspirin induced asthma attack. That's why it's not contraindicated, but it is like a warning, like, hey, nasal polyps, they bleed, right? Aspirin's going to make you bleed. If somebody has a blood clot disorder for some reason, like they have hemophilia and they can't clot appropriately, they're probably going to tell you before you give it to them. But also, if somebody's unconscious, not able to follow commands, don't go crushing up aspirin and shoving it like in their mouth. So they need to be able to follow commands.
Yeah.
They can chew it. They're not allergic to it. Be careful in asthma. You're still going to give it if they have asthma, right? What's your dose? 325, yeah. That says
Technically,
324.
the official medication range, due to the fact that we have 81 milligram tablets of baby aspirin,
Yeah.
is 324 milligrams.
Yeah, you give 4. So 81 milligrams, this is how we carry it. You're not going to go shaving off that extra 1 milligram of aspirin. You're like, oh, excuse me. Yeah. Tell them to snort it. Don't do that. Yeah. So another thing, I have been told both ways. Your book says could be contraindicated. They say according to your protocol. Where is it? Administration. Okay. Medical direction may decide if the benefit of giving aspirin outweighs the risk with the already taking blood thinners.
What's a blood thinner? Like, what would the medication be?
Like Coumadin or warfarin, something like that, where that's an actual blood thinner. Follow your protocols when it comes to that. I've always been taught just to give the aspirin anyway because of how it's working in the body. So just refer back to your protocols. We're not going to tell you that and then put something crazy in the test. So
Maybe.
if there is something crazy in the test, we'll bring it to your attention before we do it. Yeah, so they
have
weird
classes
too.
of pregnancy drugs that are contraindicated
Yeah.
for pregnancies.
They say not to give it in pregnancy, right? But then like one of the what's the word I'm looking for? Like one of the medications that they give pregnant people to prevent preeclampsia and like early term pregnancy is aspirin. So they say don't give it for pregnancy, but then they give it for pregnancy. So also follow your protocols.
Your best bet is if you ever run into that, call your medical control and just ask, and then let them decide
what they want to do from there. Yeah, because that's like a weird like little gray area where they're like don't give it, and now they're like all the pregnant people get aspirin. So in pre-hospital setting for chest pain, I would consider talking to medical control.
Radio, like you guys were able to radio them, but they can't radio back.
Yeah, so
Yeah,
I
that's
was
the thing.
explaining to folks that's been riding with us, our radio system's hit or miss. With all the power bumps we've been having recently, a lot of times the hospital can't call us or they can't hear us. So attempt to get out on our radio systems because that radio is still going to be recorded through our end. But if the hospital is not able to respond to you or anything, call them on the phone and try to get medical direction that way. It's just better to do the radio because it's a recorded system. So we've been having to do that a lot.
Yeah. All right. What is nitroglycerin? What kind of medication is it? Vasodilator. What does that tell me? Okay. It's going to dilate the vessels, right? So it's going to go whoop. So indications. Chest pain. Yeah. So suspected ACS, chest pain, right? So this is to treat the pain in ACS. So if you're thinking about this, right, it's a vasodilator. What we're hoping to do whenever we give it is one of these little coronary arteries are blocked off, and we're hoping to open it up more so more blood flow can get past whatever is causing that like clot, right? So it's a nitrate, right? Nitro, nitrate. What's your indications? We said ACS. What's your contraindications? Yeah, Viagra or any kind of, yeah. So Viagra or any kind of erectile dysfunction drugs within 48 to 72 hours. Low blood pressure. Yeah, you don't want to give it in a head injury. Why? Huh?
Heart rate low 60.
Yeah, I don't know why
Pretty
that's
sure
so
it was on
much
the
in
card.
the book. Yeah,
It's in their memo.
yeah, bradycardia, because it can affect your heart rate because it's working on your heart, right? So why don't we want to give it with the low blood pressure? Yeah. So you can, yep.
You know, I almost wonder if they don't put the bradycardia thing in there because with the inferior MIs.
I think that's what it is.
So with one of the things that we look at for like inferior MIs, it can cause a lot of bradycardia and stuff like that. So and a lot of hypotension. They have issues with the
We're
with
gonna
the
miss this a lot
circulation of
today.
the old ticker, right? And so one of our contraindications is if they're having an inferior MI, you have to be careful of giving them nitro. So that's probably why they put bradycardia in y'all's.
Yeah.
Is because if they're bradycardic, there's a chance they're having an inferior MI, and they don't want y'all to give nitro if that's the case.
Yeah. So whenever we're talking inferior, we're talking about this part of the heart right here, right? So remember what sits right here in our heart, electricity wise. Our pacemaker node, right? SA node. Yep. Good. So if that part of the heart's affected from ischemia or an infarct, there's one of the more common side effects of that is bradycardia. So they used to teach, it's really coming out of practice now, but the textbooks haven't caught up yet, that you don't want to give nitro in an inferior MI, which that's been disproven, as long as their blood pressure is okay. So I do want to touch on the blood pressure a little bit because they teach in your book a systolic blood pressure. So the top number above 100, you can give it, right? So a lot of this research that has been coming out, it's actually more dependent on the diastolic blood pressure. So the diastolic is whenever your heart relaxes, right? So that's allowing your heart to refill as it relaxes. So as that blood comes in, relaxes, and then it pumps, and then it shoots it back out to your body. So if it's less than 60, you really shouldn't be giving the nitro, because what happens is you're going to tank that diastolic blood pressure, and you're not going to get the proper blood flow to your heart because you're tanking the bottom number so much. So we want it to be around 60. But per your textbook, per your test, it's going to be a systolic blood pressure of 100. So say someone had a heart or a blood pressure of 160 over 88, and I gave the first dose of nitro and it dumped to 110 over 70. Am I going to give a second dose of nitro? No. Yeah. All right. So also for EMT basic, it has to be prescribed to the patient. So yeah. Yeah. That's between them and Jesus. They have been, if it's prescribed to them, they've been educated, which is so weird to me that they're just like, here you go, here's nitro. It's wild to me. I don't know. I get it because like it relieves angina, which is why they are prescribed, but that's just wild to me. So anyway. Yep, it's sublingual, so underneath the tongue. There's tablets. They can also have a spray. So a big thing about the spray is you don't want to sit there and shake it and then give it to them, because those little air bubbles get into like the little pump part, and you're not giving the full dose. Does anybody know the dose of nitro? 0.4. So each tablet is 0.4 milligrams, and each spray is 0.4 milligrams. All right. So whenever we give it, right, we want to check their blood pressure. We want to ask all the questions. We go through the 5 rights, And then you say, hey, buddy, I'm going to assist you with your nitroglycerin. We're going to put it up under your tongue, and it goes up under the tongue. Some people chew and swallow it. Whenever you chew and swallow nitro, it actually gets deactivated by like CP430 enzyme that's made in your liver. So if they do swallow it, it's not going to do its intended effect. So we need it to go in sublingually, right? We want it to rest under their tongue.
You said when it's sprayed, same thing.
Yep, just right under the tongue. Same kind of thing. What I used to do, the service I used to work at, we had spray. So I wouldn't shake it. I'd actually test spray the wall to make sure it was spraying, and then I'd put it up under their tongue. So maximum of 3 doses. You want to contact medical control for the 3rd dose as long as they meet parameters. And medical control might tell you to give more than that. So just keep that in mind. Usually per protocol, you can give up to 3 doses. It has to be the patient's own nitro. They meet all the criteria, all that fun stuff. Yep, 3 doses. They're all 0.4. So another big thing, what's a big side effect of nitro? It's kind of an untoward effect, right? We talked about this. Headache, that's a big one. So if they start developing a headache, that tells you that the nitro is working because everything's vasodilating. So say I give nitro and they do get hypotensive. First thing I'm going to do is not give them another nitro. Then we want to lay them flat. So what that does is it helps raise their blood pressure back up. So if they can tolerate it, lay them flat because you want to help their blood pressure come back up. Treat for shock, right? And transport promptly. If you have ALS en route, just keep them updated. So I know that there was a question with the scenarios where if your patient changes after calling a report, like, hey, I just gave a report, my patient's fine and dandy, they're doing better, then all of a sudden they go unresponsive, you need to call back and give updates. So if anything major happens like that, we want to call back and give an update.
If a patient is yelling at you that they can't lay flat because they can't breathe, don't lay them flat.
Yeah.
Because chances are they probably have something like some sort of fluid in their lung. If they have nitro, chances are they're probably susceptible to some other issues, pulmonary edema, stuff like that. And so they might have fluid in their lungs. So if you lay them flat, you're going to drown the piss out of them. Mm-hmm. They're not going to lay down. Yeah. They're going to get really mad at you and they're going to start yelling. So if they yell at you and tell them not to lay them down, don't lay them down.
Orthopnea. Yeah, so that's the inability. It's like difficulty breathing while laying down flat. So you can also get like nocturnal orthopnea, where it happens at night.
Yeah, so you can put them in like a semi-Fowler kind of Trendelenburg to try to help with that situation, but you really just need to get them to a higher level of care.
Yeah, and sometimes if you just, the effect of nitro only really lasts about 5 to 10 minutes. So sometimes if you kind of just ride that wave, their blood pressure comes back.
Yeah.
Hopefully.
Be like, spit the nitro out.
Yeah. Yeah. Unfortunately, that's what I don't like about the sublingual nitro is once you put it in, that's your dose. You can't take it back.
Nope.
Right. So we have other forms of nitro as you progress that we can give, or you can just shut it off and it stops. Okay. So cardiovascular disorders, cardio being heart, vascular being veins and arteries and stuff. So these are heart problems caused by a number of disorders affecting condition and function of blood vessels and the heart. So big example of this, your arteriosclerosis, your atherosclerosis. So athero is like a buildup of plaque and stuff. Arteriosclerosis, think artery, that actual wall of the arteries and veins is getting hard. So they're not going to have that function that they usually do where they can expand and dilate. So they can narrow and block the arteries of the heart. So you can see the little narrowing here, right? And so they get that backflow. So the buildup narrows the inner vessel diameter. So that's also called your lumen. So the inside of your little vein, your vasculature. And it's usually from a fatty deposit, right? So we have high cholesterol, you can get fatty deposits. This doesn't just affect your heart, but since we're talking about cardiovascular disorders today, we're talking about it in the heart. So risk factors for coronary artery disease, age, heredity. So it could be like, hey, that's why we like to ask, do you have any family problems or heart problems? And usually they'll let you know. Hypertension is a big one, obesity, lack of exercise, elevated blood cholesterol, right? So does anybody know a medication that your patient may be prescribed that kind of tells you if they have high cholesterol or not? A statin. Yeah,
The
good job.
world's worst.
Yeah, atorvastatin, anything ending in statin. Another one, Lipitor, sounds like lipid. Lipid is fat, so Lipitor, high cholesterol. And then cigarette smoking. So then we have angina pectoris. This could be, it's what we were talking about it earlier, where like your cardiac demand for oxygen goes up with like exercise. And so because their vasculature is not there to supply that increased oxygen demand, they start having chest pain. So normally your textbook presentation of angina pectoris is going to be, oh, I was out mowing the lawn or I was running and my chest started hurting. As soon as I sat down, it went away. Or I took one of my nitro and it went away. So usually these are the patients that have that nitro. Yeah, so that's why I put this little lawnmower dude here. That's usually like your telltale National Registry question is, oh yeah, I was mowing my lawn and my chest pain started and it went away when I sat down. What part of our OPQRST
Bless you.
tells you that? The onset, yeah. So that's why we're asking these questions, because we want to know what's leading up to whatever they got going on. Normally, your big indicator for like, oh, this is a heart attack patient or your STEMI patient is I was just sitting here doing absolutely nothing and my chest pain just started. That's your textbook presentation of a heart attack. So, if they have nitro, if they can't tell you that they have a history of angina, usually if they have nitro prescribed to them, this is what they've been diagnosed with. It dilates the blood vessels of the heart, hopefully. It's actually kind of leaving our, not so much scope of practice, but our treatment modalities. We don't really use nitro a whole lot anymore. But if somebody does have chest pain and they have nitro with them, keep that in mind. Yep. So this last one's a big one. Assume it is a cardiac problem until proven otherwise. So even if they tell you like, oh yeah, it went away with rest, I'm good, I don't need to go to the hospital, you still need to inform them that you cannot rule out a heart attack. That's a big thing, because people are like, oh yeah, I know what this is. But part of our refusal documentation is understanding that we're not doctors and it could be just this, right? But they could have a lot of other stuff going on.
So if they sign a refusal, like after you break
Mhm.
the risks and everything, and it goes down and down, would that still be like a implied consent? Or no?
Once they go unconscious, they then have implied consent.
Even after you sign a refusal?
Oh yeah. Yeah, they
Yep.
had an acute change in condition.
And they can no longer make sound medical decisions for themselves.
Yeah.
So when Mr. Lake and Mr. Holly were riding with us the other night, we had a call on a young lady. And we got her in the back of the truck, and then all of a sudden she was like, no, I don't think I need to go. I don't think I need to go. I very promptly informed her, hey, listen, like, I get what you're going through. I don't think that it's best if I leave you here right now just because of everything that, has been going on. I can't rule everything out. Let's just run you to the hospital, get some blood work done, get some tests done. You'll be back for, midnight and you can take a nap. Right. So just let them know, like, you can't do all the stuff. Just take them, especially if they're in the back of your truck. Like, me and Becca knew that this young lady probably didn't have anything major going on from the experience of dealing with the situations, but due to the situation, you still want to inform them like, hey, listen, I can't do all these things, but the hospital can, so let's run you out there and just get the test done and be done with it.
Mm-hmm.
Right. So
Yeah, so even if like say you went out on somebody with diabetic problems and they signed your refusal and you get called back out to that same house and now they're unconscious, even though they signed your refusal an hour ago, you're still going to treat them. So same kind of idea. Mm-hmm. Yeah.
the only thing that changes in that scenario is if they have like DNR, DNIs, any sort of advanced directives, stuff like that. If they just drop dead in front of you and the freaking wife standing there is like, nope, I got a DNR, then that's a whole nother conversation. But
So, I know the other one we have is like actually a DNR. They don't have to, like they don't have to show it like one time to somebody or how that.
no, so a
That's what we're
DNR has to be re-signed by a physician every 6 months. Yeah, so to have a valid DNR, it has to be signed by a physician every 6 to 12 months. It has to be recertified and stuff like that. The hospital keeps records of the DNRs. In the emergency setting, we don't keep records of DNRs. So for us to validate a DNR and to use that as a means to not do CPR on this person, they have to present it to you. It has to be valid. It has to be end dated. It has to have all its appropriate signatures.
And there's like, whenever you look at a DNR form, there's little check marks. So some of them are like DNR, but they still want IV fluids if necessary, or they still want to be intubated if necessary. So just make sure you're looking at all of that stuff too whenever they present it to you.
Those actually like relocate for things like, oh, I don't want to die.
Yep, 100%. Yeah, they can be
And
sitting there.
unfortunately, the family can revoke that too.
Yeah, the family can.
So family goes in there and like you got grandpa that's had freaking stage 4 cancer for the last 4 months and him's is freaking 67 pounds soaking wet. And you walk in there and they're like, nope, he had a DNR, but we need him saved. Grandpa's a fighter. He's going to make it. He's not a fighter. He's not going to make it. But at that point, they've revoked that DNR. And unfortunately, we got to break all grandpa's bones.
Yeah.
So.
Yeah. All right. Do you guys need a break, 5-minute break, go to the bathroom or anything? You're good? Okay. All right, we're going to power through it. So acute myocardial infarction, right? That's big words. So acute meaning what? Yeah, or within a small amount of time, right? So whenever we're referring to something acute or chronic is like they've been dealing with it with a long amount of time. Acute, short onset. This happened right now. Myocardial, what does that tell you? Yeah, myocardial is like the muscle and cells of the heart. Myocardium, myocardial, that's what that tells you. Infarction, what is that? Cell death, right? So acute myocardial infarction is what? Yeah, it's a heart attack. It's a heart attack. So you might see this AMI. They might tell you, oh, I had an AMI in the past. You might see it in paperwork. That's what they're talking about. They've had a heart attack in the past, right? So this kind of shows you that part of the muscle that's dead because that coronary artery that was supplying it has been blocked off for whatever reason. So people can have silent heart attacks where they didn't know that they had a heart attack and then they go get a 12 lead done at their doctor 6 months later. And they're like, oh, there's proof on here that you had a heart attack, right? Or you're now in congestive heart failure. We don't know why. Oh, you had a heart attack in the past, but you didn't know. So that's also another thing to keep in mind. And that's usually like those weird symptoms like, oh yeah, I was just feeling like under the weather for a couple of days. And then 6 months later, like, hey, you had a heart attack.
Just a little extra under the weather.
Yeah. So hardened plaque can cause rupture or aneurysm of the blood vessel. So if you have a little blood vessel here, your little coronary artery, and for some reason that plaque pulled off and now it's ruptured and that part of the heart's not getting the blood, AMI. I like that little heart. And then narrowing of the vessel, right? So that's why we're giving nitro if that vessel's narrowed. So here's your little coronary arteries again, but here's kind of a picture showing you like the aneurysm, like how it could present in a model wise. So you get those little aneurysms and then they cause that blood flow to just stop. So then there's a thrombus. So that's like a blood clot basically. So occlusion of blood flow caused by formation of a clot on the rough inner surface of a diseased artery. And it can break loose, start flowing around and stop somewhere. And then wherever it stops, that's where you're going to start having problems.
So thrombus comes before embolism?
Yeah, that's like the part that breaks off, causes the embolism. Yeah.
So to give something like vasodilates, you just make it pass through?
I mean, it could.
Or how's that work?
I mean, it could. It could just move further down. Same kind of thing with like strokes. If you have like a thrombus in your head and one part of your brain's affected, then that breaks loose and goes somewhere else, it can affect more.
Which is terrifying. And I have seen that in person where somebody's having a little stroke and they're like, burr, and then like all of a sudden they're fine. And then like 5 minutes later, they're like, burr, and then like all of a sudden they're fine. And it like just kind of moves around. And I'm like, I don't.
Is that
So,
how you charted it too?
Yeah.
The patient was like,
burr.
and then,
And then I was like, and then we took him to the hospital.
yeah.
Yeah. Yeah.
Yeah.
Yeah.
So ischemia, it can cause all sorts of problems, right? So injury to cells and then cell death. So it can lead to infarction. And then it can also disturb the electrical function of our heart. So our heart all has electrical pathways that are all talking to each other all of the time. So if you get a part of the heart that's no longer talking, that heart's going to get pissed off for whatever reason. And you can actually see it like on the 12 lead. They can start throwing PVCs. They can go into VTAC. They can go to VFib. So there's a lot of different things that can happen. Dysrhythmias. So dysrhythmia, arrhythmia. From my research, dysrhythmia and arrhythmia are the same thing. If anybody knows anything else, please let me know, because I was trying to figure that out in medical school. Like, what is the difference? Because somebody calls it an arrhythmia and some people call it a dysrhythmia. They're the same thing. So there's any kind of irregular rhythm. So whether it's originating from the top part of the heart or the bottom part, there's something wrong with their heart. It's an irregular heartbeat. And then you have your mechanical problems, so any kind of cardiogenic shock, right? So we think of shock being three major parts. We have the pump, we have the vessels, and then we have the whatever's filling the vessels, right? The blood and plasma and all that stuff. So cardiogenic shock is affecting what part of the pump system? The pump, right? So if your heart is not adequately pumping that blood around, you're going to go into shock. And then sudden death, right? So sudden cardiac arrest for whatever reason, whether it was from a dysrhythmia that was no longer pumping blood correctly, whether it was from a mechanical problem of that heart tissue actively dying, that can cause cardiogenic shock. And then any kind of disconnect in the way our heart cells talk to each other, that can cause sudden cardiac arrest. They say it can be within 2 hours of the onset of symptoms. It can be longer than that, and it can be shorter than that. So, but textbook within 2 hours. So treatment of your acute myocardial infarction, they come in and do a balloon angioplasty. They come in and they open up your vessels for you. They place stents. If somebody has a history of like a cabbage, like a coronary artery bypass surgery, they actually go in and like move their little arteries around so they can get blood flow where they're supposed to go. But usually that's associated with stents. So if someone ever tells you, oh yeah, I had a heart attack, I had nine stents placed, that's telling you they probably have an extensive cardiac history, right? Fibrinolytics, blood thinners. They give them blood thinners. And then upon discharge, your patients that have had a heart attack and now they're discharged, you'll see them with daily aspirin. A beta blocker is going to affect their heart rate, and sometimes it's used for like a blood pressure medication. And then the blood thinner, so that Coumadin, the warfarin, that kind of stuff. So primary, secondary assessment. We walk in, hey, my name's Becca, what's going on today? ABCs, right? Circulatory. They might present cool, pale, diaphoretic. They might have an irregular heartbeat. They might have no heartbeat. At that point, it's a bigger problem. So identify symptoms. So yeah, I have the chest pain, it radiates to my jaw, or I have back pain, or I have left arm pain. If you have a high index of suspicion for a heart problem, treat it as an AMI. 12 lead, less than 10 minutes of patient contact. Whether you're on an ALS truck or not, if you have the ability to do a 12 lead, please get it done within the first 10 minutes.
7 o'clock.
All right, contact ALS, all right, so we can interpret the 12 leads or give extra medications. Be prepared for cardiac arrest. So that's a big thing. If I have a patient that I'm like, yep, that's a STEMI, or there's like obvious heart rate changes or anything, I'm going to be putting the pads on the patient even if they're talking to me. And I tell them, like, I'm just going to take a bigger picture of your heart, just because these patients, besides GI bleeds, these patients like to code right in front of you. because their heart is being damaged, right? And then aspirin and nitroglycerin if indicated.
So, does anybody know where our closest cath lab is? Elko. You know the fun facts about Elko? They are not a 24-hour cath lab. So, with these patients right here, if you have a high index of suspicion, and I say this mainly for the mine rescue folks, the folks in Golconda, stuff like that, right? If you have a very high index of suspicion that this person may be having a cardiac related event, you need to get air resources in the air quickly because the closest cath lab is Elko, but they are not 24/7 cath. And so they may be there, they may be not there, and they may have to go all the way to Reno. And so getting them out of there quickly, effectively, a good thing, that people don't understand is with the ALS stuff, when the flight companies come in, they can give blood thinners, they can do a lot more medications. And so they're able to kind of stabilize them a little bit better. And so trying to get them out of there quickly is the best practice, but make sure you have a good high index of suspicion that there's a good cardiac event going, and then call for your air resources or ALS, whatever you need to try to get them out of here.
Mm-hmm. Yeah. I will also say, this is kind of like a side note. If you ever have a patient that is presenting with stroke-like symptoms, like facial droop, whatever, and chest pain at the same time, it is a dissection, an aortic dissection, or some kind of artery dissection until proven otherwise. So keep that in mind. We'll get to that later, the other signs and symptoms. I think
and that's when you pray for the sweet Lord above to watch over your ambulance.
Yeah, because you can't do shit for that. All right, heart failure. So CHF is usually how this is referred to, congestive heart failure. The heart is unable to pump blood efficiently. So we talked about like the right and left side being affected, but most of the time it's both sides. Your number one cause of left heart failure is actually high blood pressure, because that's pumping towards the rest of your body. And whenever you have chronic high blood pressure, your heart's a muscle, right? So pumping hard against the rest of your body, and that left ventricle is going to get really fat and big, and it causes left-sided heart failure. And then the number one cause of right-sided heart failure is left-sided heart failure. But you also have like pulmonary problems that can cause right ventricle strain. So the ability to perfuse the body tissues is impaired. So that's where you start getting like your edema. You might get people, you'll see like chronic cardiac problems. They'll get like clubbing of the fingers. So I don't know if you guys have ever seen clubbed fingers before. I can try and find a picture and pull up, but their fingers literally like curve like this. That's a sign of a chronic cardiac issue. There's another one, I don't know why it's on the ear, but it's called Frank's sign. So you actually get a line right here on your ear. And if you walk in, you see like old man with like a lot of heart problems, they'll get like this Frank's sign, and I'll try and find a picture of that too. It's kind of interesting how our bodies kind of adapt and change to like low perfusion all the time, right? So right-sided heart failure, this is where you get that JVD. Here's a picture of it. You can see that jugular vein gets distended, swelling and fluid buildup in the abdomen, so their belly might be more stretched out than usual. I usually like to ask patients that I'm like suspicious of, like, hey, does your belly feel more swollen than usual? Because to me, I could look at somebody and be like, oh, that might be normal to them, but I'm not going to assume that. So I always like to ask. And then your pedal edema, right? So on the feet. Yep. Another place that you'll see the fluid buildup is sacral edema. So right here in this area, if they sit down a lot, if they're very sedentary, they'll get a buildup. It looks like it's swollen right here above their tailbone. Mm-hmm.
Mm-hmm. When you have a patient laying down, how do you know the difference if it's doing you just going down or doing you an actual buildup?
So if these folks have a buildup of fluid, chances are they're not laying down.
Yeah, true. Yeah, you can make anybody have JVD. So you can like lay them back and actually push on their liver, and it makes you get JVD. So yeah, you can either just sit them up as you walk in, try to like look for it, But usually they don't tolerate laying down. But if they are unconscious, unresponsive, and you have them laid back, I mean, there's not a whole lot you could do. You can note it, like, hey, I noted JVD.
How do these people normally sleep? Yeah.
Pillows,
They sit
recliner.
propped up with a bunch of pillows, sleep in the recliner, sleep in the couch, whatever they can do to sit up. So chances are if they have JVD and they're like sitting up like this is what it's more associated with versus like, because we actually shoot IV into that vein right there. We can shoot an IV into that vein right there, but a good way to do that, you just lay them down flat, like she said, push on their liver, and you kind of get a backflow of blood. You can shoot a vein or shoot IV in that vein.
Mm-hmm.
So you can call somebody to have this, but if they have this and they're still sitting up, then
You got problems.
you got other issues.
Mm-hmm. Yeah. Yeah, so you can actually start getting, like, it's called weeping edema, and it's very icky. But basically, they just get so much fluid everywhere that it just starts to leak out of their skin.
It's freaking gross.
And it can be anywhere. It can be in the hands.
Their legs will start cracking. Their fingers, like you press on their hand, and it just leaves a big dent.
Mm-hmm. Yeah, and that's like a later.
Like their skin will start
sign,
getting
so
like moist
usually
and
the first
wet.
sign you'll see is the
Gross.
pupil edema, but you can get it.
And we've had it so bad that we've laid patients on stretchers, and like when they get up, you can see the imprints of their legs and stuff on the stretcher from that weeping edema.
Mm-hmm.
It's like the interstitial fluid.
Mm-hmm. Yeah. Mm-hmm. Yep. It's just bore flow, and so it's got to pile up somewhere.
Past the least resistance.
Yeah.
Yeah,
I've had like edema so bad on patients that, like, to start an IV, their hand was so swollen up, I had to like hold their hand for a little while to get that like edema pushed out of the way, and then all you could see was a little tiny bit of blue. And I was like, okay, I'm sticking it, just because it's so like swollen. It's hard to get IVs on these people. Sometimes it gets so bad on the legs, like their legs are so big that our IO needles aren't long enough to actually reach their bone. Like they get pretty nasty. And like I said, I think last week, if somebody's got chicken legs like this, still like push in on their legs, because you can still get edema and it won't look like they have edema, but once you push in, it leaves an indentation. Yeah, so you should be checking that. So then left-sided heart failure in comparison to right, pressure builds up in the left atrium and then in the pulmonary vein. So this is where you get like your pulmonary edema. So remember, it's wherever the blood was before that part of the heart is where that fluid builds up. So left-sided is the lungs, right-sided is the body, right? Can be life-threatening. Does anybody remember what, like if someone has flash pulmonary edema, what are you going to see? Yeah, what are you going to see like externally? Yeah, it's foamy and it can be pink. Yeah, it'll look like strawberry milkshake. Very icky.
It is terrifying.
Yeah. So this just visual representation. This is from the body, right? It goes into the right atria, right ventricle. If this is failing, all of this is going to back up over here. Whereas if your left side's failing, it's coming from your lungs. So this is failing and it's going to back up into your lungs. So the blood flow, right atrium, right ventricle, it goes into what's next. What is this? Pulmonary artery. Good job. To the lungs. From the lungs, what's this right here? Left atrium. This here, left ventricle. What causes your left ventricle to get all swollen and fat? High blood pressure. Good. So your assessment and your treatment of heart failure patients, the big one is going to be obviously just treating the signs and symptoms. If they're hypoxic, if you hear crackles, give them oxygen. Keep them set up. They might have difficulty breathing. They may not. Sometimes they're just not alert enough to tell you they can't breathe, or they haven't been able to breathe for so long, it's not really that much of a difference to them. I think this is a video of crackles. Yeah. Yeah, this is rails. Rails, crackles, same thing.
Do they have a word together, like that's why it's
Oh, they're kind of interchangeable.
Yeah, I think it's interchangeable.
I don't really know why they did that.
They're like, this one has 2 names.
Yeah.
Figure it out. So it's kind of like that bubbly Rice Krispies. This is that one. If you have long hair, you can roll it, and that's what it sounds like.
So why does this say that there's no like there's no certain point in which you might hear this in the lungs? Because what's going to happen? Well, you're just going to have a continuous buildup of this fluid, right? And so when it first starts, it starts down low because fluid settles low, right? Well, then it just keeps building up and building up and building up, right? And that's eventually where you get to the point of that flash pulmonary edema or pulmonary edema, and they start gurgling and spitting that sputum up, is because it started low and then it's just building up, building up, building up, and it ain't got nowhere to go, and so it starts coming up top. They ain't going to. They're not going to be able to breathe. And so a lot of them will tell you that it feels like they're drowning.
Yeah. So the flash pulmonary edema patients or pulmonary edema patients that I've dealt with that are like real bad, you walk in and they're tripoding and they will not, like, you have to coach them to even just like sit down enough on the stretcher to put their feet up. They don't want to. They're sitting there and they're like, I'm keeping my feet right here on the floor. They'll stand up. They won't sit down on the stretcher. They're very like anxious. They're not.
I can't breathe.
Oh yeah, you'll hear about it for sure. Yeah.
That's the people you're saying put their hand on the freezer.
Yeah, they like to do that for some reason. I don't know. Yeah, so just listen to your patient. Don't be like, we have to lay you back because I need to ventilate you. Like Chaz showed, I don't know if everybody was in there. Yeah, you were. Everybody was. With the CPAP mask, like if you're putting a CPAP mask on and you get to the point where you have to actually bag them, that thing will stay on even if they're sitting up straight, right? So make your patient comfortable. If you are suspicious, bless you, of pulmonary edema or flash pulmonary edema, if they are not altered, if they can still follow commands, all that fun stuff, remember our criteria, we're going to be putting them on CPAP. So that CPAP is forcing air into their lungs, forcing that fluid out of their lungs. Same kind of thing. Whenever you follow your medical sheet and it's a cardiovascular problem, start at the airway, breathing, circulation. Appropriate oxygen therapy in a bad case would be CPAP. And then you get your history taking. Okay, you guys are going to get very familiar with going through these skill sheets. Don't say we didn't warn you. So treat signs and symptoms. If they're hypoxic, give them oxygen. If they're not breathing well, ventilate for them. Put them on CPAP, whatever. And then nitroglycerin as well. So if they're having that chest pain. So another thing that nitroglycerin does that's kind of cool is it helps dilate the vasculature at the end of your alveoli, so where that oxygen exchange takes place, and it helps open that up so where if they do have pulmonary edema, that pulmonary edema in conjunction with CPAP will actually get forced out of the lungs easier. So that's kind of cool thing that nitro does.
I have a question, just really curious. Where does the fluid go if you push it out of the lung?
We're hoping for it to go back into like the vasculature. So the problem is it's outside of the vessels. So it's in the intravascular space. So we're hoping to get that fluid back into the vessel so it can be expelled.
Well, when this stuff comes up, that's not going to affect the CPAP, right? Like it'd be like vomiting or.
Not so much.
So
you're still going to give a positive pressure ventilation.
Yeah,
you're trying to push it back.
But you want to clear their airway out first. Yeah, because you don't want them to aspirate, right? So if they're actively like freaking, and you'll know, right? It's a very, very scary situation. But if they're like blah, 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 and they're spitting all this stuff up, grab a suction real quick, stick it in their mouth, and then put CPAP on them because you don't want to. I mean, they're realistically, right? Like, what is aspiration? Vomiting stuff, right? Like you're pushing fluids into their lungs. Is that a huge issue if they're so backed up with fluids that they're coming out of their mouth?
There's already fluid in their lungs. You're trying to get it out.
Yeah. So you can take the time to try to suction them out real quick, and just suction their mouth clear and then stick that CPAP on them. But honestly, if they're that far to the point that they're backed up with fluid that much, they already have a bunch of fluid in their lungs. Like you're not gonna aspirate them because they're already technically aspirated, if that makes sense.
Mm-hmm.
So
Yeah. So aneurysm. So there's different types of aneurysm. They love to teach the AAA, which is an abdominal aortic aneurysm, but there is other types of aneurysms that can occur. This is the one that they like to teach you, the big scaries, right? So you get the signs and symptoms. It's usually chest pain. If you hear a test question or see a test question that is shredding or tearing chest pain that radiates to the back, it's a AAA every single time on the test. In real life too, if they're like, oh, it's shredding, like it feels like it's tearing me in half from the inside, that's going to be your AAA. So what would you not want to give somebody that's actively bleeding into their chest? Aspirin. But what if they tell you they had chest pain? Would you still give the aspirin? Yeah, no. If you have a high index of suspicion for an aneurysm, do not give aspirin. Do not give nitro. The treatment for this, keep them calm and drive real fast.
and avoid the bumps.
And avoid the bumps. Yeah. So signs and symptoms. So what happens is the sections of the artery walls, they get weak. And then our arteries are actually made up of like little layers. So what happens is one of those layers will get a tear. And so that blood will start to go in between the layers of the artery walls. And then it starts to balloon out and then it ruptures. So that's how we get this ballooning from the inside. There's like different little parts of the lumen, the walls, and it'll go in between those walls and it gets all big.
How do you fix this? Once,
Surgery.
That's it. That's all you can do is try to get them to a surgeon as quickly as possible.
Mm-hmm.
Chances are you're probably not going to make it if it tears, but you can try.
Yeah.
How long do you got?
It depends. So it depends on their heart rate, because if their heart rate shoots up, they're bleeding out faster, right? So it depends. There's a lot of different factors, but not long usually.
Yeah.
Especially
Chances are if you have a dissecting aortic aneurysm and you have a ruptured aortic aneurysm anywhere in this town, they're going to die. Like that's just what it is.
Yeah.
I heard if you're not on the operating table when it happens, you're not.
Yeah.
Yeah.
It's very rare. So signs and symptoms, it is similar to ACS. So it's important to keep this kind of on your list of differentials of your field diagnoses whenever somebody's telling you that they're having chest pain or weird symptoms, belly pain. This sharp tearing pain, that's going to be your indicator that it is an aneurysm. So if you're feeling on their belly and you feel pulsating mass, don't go pushing real hard.
Yeah, don't touch it.
So usually your test questions, sharp tearing chest pain, or you go to palpate the abdomen and you feel like a pulsating mass. You should have little flashers in your brain that's like aneurysm. Another thing I've seen is like lower here, like these iliac arteries. So this splits and go down each leg. This is right about the level of your belly button. So I've seen patients where just like one of these is actually like dissecting and their legs look just like this. So they get like this mottling and they're not getting perfused. So like obvious changes. Another thing that is really common in like the test taking world is abnormal blood pressure. So you get a blood pressure on one side and another one on the other side, and they're vastly different. So checking blood pressures on both arms, losing pulses in one arm or the other, that's another big one. An aneurysm can cause stroke-like symptoms. It can cause, they present 100 different ways.
Mm-hmm.
But like I said, if you have a stroke-like symptoms patient and they're having chest pain or a heart attack at the same time, like if your paramedic looks at the 12 lead and says, oh yeah, this is a heart attack and a stroke at the same time, the chances of a heart attack and a stroke happening at the same time is less than 1%. So it is an aneurysm until proven otherwise. All right, this is the last slide. I didn't keep y'all too long. Look at me, I didn't go on a tangent. So 62-year-old female, actually let's use a cup of doom. I hear, oh. Oh, Garrett's not here. Look at you. Yeah, you do. And then usually it's hard because we're like, what did you say? And then it's like echoing. All right. So a 62-year-old female has been complaining of shortness of breath and chest pain for 15 minutes prior to your arrival. When you arrive, you find the patient conscious, but with a difficulty breathing and an oxygen saturation of 88%. What steps should you take in caring for this patient? Okay, so what kind of oxygen might, from the information that you have, what kind of oxygen would you consider? Okay, I like where you're going with the positive pressure. What's another thing that gives you positive pressure? CPAP, good, I like it. Okay, all right, somebody else. So we have oxygen. What else are you going to do for this patient?
Besides like asking her medical history,
Okay,
maybe assisting her with nitro or an aspirin, her answers.
good, I like it. What's your dose for nitro? Good. Andrew? Good. I like a set of vitals. So you have nitro in your hand, ready to give her. And her blood pressure comes back 98/42. Are you going to give her that nitro? Why not? She tells you, my doctor said I could just take it. Why can't you give it to me? Too low. What's too low? Okay, so what can it do to the already low blood pressure? Make it even lower. Good. Carly, what else are you going to do for this patient? Good. So your partner is an EMT basic as well, and they say, but we can't do 12 leads. What are you going to tell them? Good. I like it. So you did the 12 lead, and your medical direction says, hey, I got your 12 lead. They're having a big old STEMI. Isabel, what are you going to do? Yep.
Yeah, the old doctor said he's having a fat heart attack.
Yep. What else are you going to consider for this patient?
So, they're complaining of shortness of breath, so she's still healthy.
Mhm.
So she has mental status. When she arrives, is the pulse ox already on, or would you figure out like dissecting this question? Okay, so you have difficult breathing and oxygen saturation of 88.
Mhm.
Would that be after you put the pulse ox on, or would this be?
This would be right before you put the oxygen on. It's at 88%.
Miss Miranda already set her up on CPAP, though.
Yep, she's on CPAP. We'll say that her oxygen saturation is now 94. 95. We were 95. I would keep her on the same amount of oxygen because she's still within that 95 to 99% range. And 88's kind of low, right? Especially if someone's used to sitting at 95%. So reassess her vitals. I like it. So we'll say that her blood pressure is now 110/72, and she's breathing better. Her oxygen saturations are better.
She's still having a fat heart attack.
Yeah, that's the big one. That's what I was waiting for somebody to say. Transport this patient. Right.
Have they asked her pain how it feels?
Yeah. Someone said history taking, like get a good history, you said? All right, Amanda. What kind of signs and symptoms, what are you going to assess on this patient specifically?
You're going to be checking their pulse rate, you're going to be checking their color, their temperature, their how cool or warm,
Mm-hmm.
their how
Yeah.
seeing if they're going on shot.
Mm-hmm. Okay, good. So you did she's cool, pale, diaphoretic. Did you say lung sounds? Okay, so we're gonna listen to lung sounds. You hear crackles. What does that tell you? Edema. Good. Pulmonary edema. I like it. Alex. So your partner's like, we should look at her legs. Why should you look at her legs? Okay. Yeah. So she has chicken legs, though. Does it matter? Okay. So how are you going to check her legs? Yeah. Good. I like it. Cool. Good job. Let me see if I can. Huh?
What kind of hospital do you want to try to get this patient to? A trauma? Cath lab? A cardiac capable facility. So most what they would consider a cardiac capable facility is a facility that has a cath lab there. And again, that all becomes medical direction, right? So when you call this medical director and he's like, yeah, she's having a fat STEMI, be like, okay, cool. Do you want me to bring her to your facility, or would you like for me to call Air Resources and try to get her to a more appropriate facility, right? Because can Battle Mountain do cath? Absolutely the frick not, right? The best they can do is put her on heparin and send her out of here. So be mindful of that when you're on the phone with a doctor, and say, hey, like, where you want me to take her? Like, you want me to bring her over there, or what you want me to do?
All right, so this is that Frank sign I was telling you about. I'm not saying you have to look for this on everybody, but if you are seeing this, it could be like an indicator, right? So you see the little crease at the earlobe. And then another one is the clubbing of the fingers. So this is a good picture, but this is also a really good picture. Sometimes it's not always this bad, but that clubbing, they've been dealing with cardiovascular problems for so long, they start to get like anatomical changes because of the low flow. So
That's for like a really long time.
yeah, this is a long time. It's like a chronic issue. But some people just don't go to the doctor, so they're like, I have no history.
Dang,
And you
that's
walk
crazy.
in and they look like
You
this,
got
and
them
then they
freaking
can't
hands
breathe,
for a
and
while.
there's other things going on. So that's also another really important question to ask people, like, when's the last time you saw a doctor? Because there's some people, they say, I have no past medical history, and you're like, cool, they're healthy. And then you walk in and they should have been to a doctor 10 years ago. But yeah. All right. What questions do you guys have?
So let me get this right. Not only can we put leads on, but we can do the whole 12 lead.
You can do the whole 12 lead thing.
So
Yep.
listen, if you are ever,
Right.
after this class is done, and I am going to preface this by saying I am not allowed to read 12 leads over a telephone. I am not a medical director, and I am not going to be able to diagnose your patient over the telephone. But if you're ever in the field, if you're ever riding on an ambulance somewhere else, you know, whatever, and you run a 12 lead on a patient, it looks really weird. If you send it to me or Becca, you know, that way, you know, I mean, if you just want more information on it, we'll try to, you know, talk you through it, you know, and stuff like that. Post class, we're not going to dive into 12 lead interpretations and, you know, all that stuff prior to class, because Becca will absolutely talk you into it whole and you will feel like you have not learned anything. Trust me, I've been through cardiology. It's rough. But post class, if you really want to learn about 12 leads and kind of dive off into that, if you let us know, we'll be more than happy to, you know, help you afterwards. Yeah. So do not, for the love of everything holy, please, for the love of God, don't believe what your monitors say. Your monitors will 100% spit out some bullcrap rhythm interpretation. If your patient has like a little bit of vibrations in there, it'll give you a false reading. If there's a million things that can cause false reading on 12 leads. And the other reason why I say that is because if you further your career and you go through A school and paramedic school, a lot of paramedics that aren't super comfy with cardiology, they rely on those rhythm interpretations on the 12 lead. What everybody that does not work here doesn't know, and what everybody that does work here doesn't know, is once we swap monitors and we get these new Zolls, I'm going to push Mike to make sure that we turn off that feature on our monitors, so that it no longer gives you a rhythm interpretation. For Austin, it's different, right? Because, you know, they're working on an AEMT level. So them having that kind of interpretation really isn't a big deal. But well, I don't even
It
think the
can tell you.
Zolls. I don't
The
think the
Zolls
Zolls do they?
Yeah, they'll say possible arm lead reversal.
Yeah.
Oh
Yeah.
yeah.
Yeah, they will.
Yeah, I still do it to this day. If I'm standing like on the wrong side of the patient, I'm like right, left, put it on wrong, and I'm like, oh crap, I got to redo it.
So we're going to do our test over this Thursday. Be ready. And like I said, make sure you read these questions, double read the questions, triple read the questions. I'm not trying to fail you. I'm just trying to make you critically think about things so that you're ready for National Registry. See you later, alligators.
Ready, break. Yeah, answer.
Do what?